headache of your entire life. So our first speaker is Dr. Amato, and this is talking about interactions, ventilation among lung zones.
Good afternoon. I feel honored to be part of this session. And we are going to talk about ventilation between lung zones. This started many years ago when we started to see some pendeluft between lung regions, and I was trying to understand. For instance, in this patient with ARDS, we have on the right side of the picture, we have the PV curve, okay, of this patient, inspiratory and expiratory, and here we have a slice at the level of the diaphragm, close to the diaphragm. And then this particular patient, we were starting to do our recruiting maneuvers, and then we had a slow inflation maneuver, and we decided to do inside the CT machine. When we did it, we observed something interesting because the whole inflation of the lung started in just one lung region, which was the right side of the lung, non-dependent. But then at a certain point, we started to inflate the left lung. And then it was clear to see a gravity-dependent inflation of the lung. And the first thing that caught my attention, I'm going backwards here, is that contrary to my understanding at that moment, I was expecting to see the crossing of the inflection point of the PV curve with a big recruitment of the lung, and this didn't happen. I could just see some inflation of the upper lung. And then, okay, then going on with the curve, we could get up to 50 of pressure, and then we had complete recruitment. And then I could see that most of densities of the lung could be reopened, to my surprise too. I could get a wonderful PO2 here, but obviously I had some hemodynamic problems. And then when we went back, we had lots of hysteresis, and for instance, staying here across the inflection, around the inflection point, I had a kind of open lung. And then when I started to get back, I had the collapse again, like an implosion of a building. So you start collapsing from the bottom. Let me repeat this sequence here. You see, it's like a crashing of the building, collapsing on his own weight. This was more interesting. This is another patient with ARDS. The first thing that caught my attention is that the seizures, so the division between the lower lobes and the upper lobes, I put in yellow here to facilitate your view. And I could see that somehow, look at here, the lower lobes were more inflated. At this point, the patient was under ZEEP, no PEEP. The lower lobes were more inflated than the upper lobes. And why this happened? Because I think the only explanation here is that we have some air trapping, right? And then we started the inflation of the lung. When we did it, to my surprise, look what was going on. You see that the upper lobes are increasing in size and the lower lobes are decreasing in size. They are suffering reabsorption atelectasis because this is lasting up to now 50 seconds. So I'm inflating the upper lung, the lower lung is kind of disconnected from central airways, and then I have these reabsorption atelectasis, but then at a certain point I reach a critical opening pressure, and then I started to inflate, you see, I started to inflate the lower lobes. But then I couldn't go on because the pressure was already very high. But it was clear that we had two movements here, and once we started to inflate the lower lobe, we could somehow decrease the overdistension of the upper lobe. Okay, we started to do some electrical impedance tomography studies because these CT studies were very difficult to perform and obviously lots of radiation. And this was the preliminary device that we had, the first that was working clinically. I'm very grateful to the University of Sheffield in England. And then in one patient, we were performing a PV curve, and we had this weird shape in the PV curve with a clear peak here. And then, so this was performed with a constant flow inflation, so it was weird to see this. And let's see what we could see on the images. First, I see that I'm inflating the upper left lung a lot. Maybe I have some shift of the mediastinum here, but I can see that only the left lung, upper, is inflating. Then we go on. I start to see some inflation of the lower lobes, but look at what happened at the peak. Suddenly, I reopen something here, and I start to inflate the right lung. And then this caused a kind of shift in the mediastinum, and then I can see some pendeluft here also. But this all happened during an extreme maneuver. Let's see if we can see those kind of weird movements during tidal breaths. This was the beginning of our EIT project. And now we have much better images, and we can have at the bedside. And this is a sequence that I collected using large tidal volume, not that large, 10 mL per kilogram in a pig. So I'm repeating the sequence now in real time. You see what is going on here? The inflation of the lung starts at the top and then goes down. Why this? Because of the pleural pressure gradient. We are looking at the physiology. The pleural pressure gradient is increasing from the upper lung to the lower lung according to the gravity axis, and then the transpulmonary pressures are progressively higher in the bottom part of the lung. And then the air first goes to the upper lung, which is easier, and then goes progressively to the lower lung. And this can be observed in normal lungs or diseased lungs, is the same. We only had the chances of looking at this because we have now new technologies. So I'm just going to repeat this. But this kind of heterogeneity you see all the time if you are not using a proper PEEP level. You can abolish them if you have all the channels open at first when you start the breath. More recently, thanks to the development of the technology, we have now some more evidence that during spontaneous breath, you can have something even more weird that we were not expecting. Now, look at this. This is tidal breath in a patient. This is a post-operative patient, cardiac patient. He's receiving pressure control ventilation and have a very high level of sedation. So I think this is what I was expecting. So he's receiving a very homogeneous ventilation. It's very difficult to say that ventilation is starting in one part of the lung or the other. Looks like very homogeneous. But then the patient was being superficialized, and then so anesthesia was going on, was getting out of his body. And then after some minutes, we started to look at this pattern of ventilation. This was surprising to me because in all the cases I showed you before, the pattern was the opposite. It was starting at the upper lung and going downwards because of the gravity axis. That was expected, but this was not expected for me. So clearly the ventilation was starting in the lower part of the lung and then propagating to the upper lung. If I would represent, this is what was going on. We are starting a dependent lung zone, ventilation, and then going upwards. Just an important remark here. When you look at these images in EIT, EIT is showing you changes in air content. It's a relative image. I can only see changes in aeration. So this can be understood as a region of ventilation. And there is good studies showing that the proportionality between air content and the EIT signal is almost linear. It's very much close to the linearity. So you can assume that this is really regional ventilation. So certainly for some reason now I'm starting ventilation in the bottom of the lung and then going upwards. So how can this be possible? Let's take a deeper look on that. You can transform the pixels in the images of EIT into a signal, like a plethysmograph, a regional plethysmograph. And then when you look at these images, I can see what is going on with the plethysmograph in the upper lung zone and the lower lung zone. And then in this red region here, I'm showing you the paradox, the kind of Pendeluft, which is the inflation of the bottom part of the lung together with the deflation of the upper lung. So at the very moment that this region is inflating, this region is deflating. And then I get rid of this overinflation in the bottom part of the lung, and then I had what I was expecting, that is an inflation of the upper lung according to the pressure, positive pressure of the ventilator. When the patient was paralyzed, I see here pressure-controlled ventilation. I could see simultaneous inflation of the upper lung and of the lower lung. Interestingly, the tidal volume during paralysis or during spontaneous breath was about the same. So I had this kind of Pendeluft, and it was really a Pendeluft because the overall tidal volume didn't change. I was just moving air from the upper lung to the lower lung without a big change in the tidal volume. So this was what was going on. So I had a simultaneous deflation of the upper lung followed by, or simultaneously with an inflation, overinflation of the bottom part of the lung. And we have to say that this is Pendeluft. So we found this a little bit counterintuitive because, as I showed you before, every time we saw these weird movements, they were always starting at up and going downwards, not the other way around like in this patient. So we decided to perform an experimental study to explain these findings, and then we went to the lab and we started to study a little bit better how physiology tells us that the pleural pressure is transmitted. And in most of the physiological studies, we found an explanation that the lung is behaving like a liquid body in most circumstances, which means that it's like in a liquid body like this, if you move the embolus of this syringe, for instance, you pull the embolus, you are going to cause a negative pressure here, which is going to be transmitted homogeneously across the whole structure and almost instantaneously. In fact, is at this speed sound, the speed of the sound. So, but it's practically simultaneously. Okay. So, which is the difference between a liquid body and a solid body? If you have a liquid body and you put, for instance, a weight here on top of it, and suppose that I have here my pleural membrane, what is going to happen is an instantaneous transmission of pressures across the whole body. If I have now a solid body, it's going to be a little bit different because the weight is going to be transmitted, the force or the deformation caused by the weight is going to be transmitted locally, and I may have a let's say, localized atelectasis. So when we started the pleural studies, the pleural pressure studies in the physiologies of the 50s or the 60s, most physiologists were considering that the pleural space or the whole body of the lung would work as a liquid body. And this is why if you have a kind of diaphragmatic contraction, you have -10 of pleural pressure, this is going to be instantaneously transmitted to the whole surface of the lung. And this is the essence of using an esophageal balloon that you put in the middle of the lung, and it's going to give you an idea about the pleural pressure. And old studies performed by many physiologists that I'm not going to list here, but we should say that they were very smart people, much more than we are. And they did lots of studies trying to understand if the pleural pressure transmission could be different in different spaces and different parts of the lung. And especially if in the top of the diaphragm, they would be different. But consistently, they showed that the pleural pressure was very homogeneously transmitted, except in one condition. When they had unilateral ablation of the phrenic nerve, and then they could have an extreme deformation in one of the lungs, and the other one was silent. At this case, then the transmission was not very homogeneous, but then they were causing such a deformation in one lung that the lung could not behave as a liquid body any longer. So as I told you, this is the essence of the measurement of pleural pressure, and then the classic maneuver to check if the pleural pressure is in a good place or the esophageal pressure is reflecting your pleural pressure is that you perform an occlusion maneuver. And then you are expecting that the delta pressure that you see in an occluded airway has to match the esophageal pressure change. So the assumption here is that you have a liquid body. Okay. So then we are puzzled by the concept that, okay, how come that we can have a pendeluft here? Because if the pleural pressure is transmitted across the surface of the lung, I should have a homogeneous inflation of this region and this region. So how we can explain that we had a deflation here? So we went to the lab, and then we look at the pigs, and then we saw the same thing that in the patient. So during paralysis, very homogeneous, but during strong effort, and especially when the animal had lung injury, we could see that we had, again, this kind of pendeluft with inflation first in the bottom of the lung and later in the top. Again, the same tracings that we saw in the patient and the same tidal volume. We confirmed the findings using CT. It was not an artifact from our EIT device. I'm going fast because I would like to tell you our conclusions. So what we realize is that whenever we observed this pendeluft, we had a situation in which we had a departure from the classic physiology, because we had a situation in which we had a kind of bridge of solid tissue here, and then the transmission of pressures in this case is not homogeneous. So you need atelectasis and a strong lung deformation, and then you may have local pressures in the pleural surface that are not going to be transmitted to the rest of the lung. And then in this condition, your esophageal pressure can underestimate the real pressures applied to the parenchyma. Like in this situation, if I have a gel inside this syringe and I make a strong pull, I may have a delta pressure here that is higher than the delta pressure in the rest of the structure. This is the behavior of a solid body. We confirmed this with special sensors placed in the pleural surface, and we could observe that in special situations when the patient has severe lung injury, he may have a local pleural pressure which is twice the pressure that you measure with an esophageal pressure or that you can measure in the rest of the surface of the lung. And this can explain sometimes these weird movements. The message: either during controlled ventilation, if you see this pattern of gravity-oriented inflation, this means severe lung heterogeneity. And if you are under assisted ventilation, you see the reverse. The first inflation in the bottom part of the lung, because local pressures in the diaphragm are higher there, it means severe heterogeneity. And I believe that in both circumstances, you are in trouble and at a higher risk of ventilator-induced lung injury. Thank you very much.
Wow, that was absolutely fascinating, terrific, and completely new. Questions from the audience?
Hi, Marcelo. It was an amazing talk. Thank you very much. And do you think it's a physiological explanation for the neuromuscular blockage randomized trial that you showed most of the time when the animals were paralyzed, the ventilation were more homogeneous throughout the lungs?
Oh, thank you for this question. Yes, when we tried to convey the message for this publication, trying to say that this is another mechanism that may explain the precise results of this trial. So it's easy to understand that during muscle paralysis, you can avoid breath stacking, and you can avoid larger transpulmonary pressures. But here, we are showing that even if your tidal volume does not increase, you may be in trouble because you have a local tidal volume that is very high in the bottom part of the lung, but then it goes back, and then you don't see on the ventilator. So it's a high local tidal volume that gets hidden in the middle of the breath.
I love this stuff. But question for you, how do you handle since the pleural space is a fluid, how do you handle the hydrostatic gradient? Because you were saying it's the same all around, but clearly the pressure has to be higher in the bottom because of the hydrostatic weight.
The idea is the following. I have a hydrostatic gradient, so it means that the absolute pressures are lower here and higher here. But when I have a swing, they all have the same delta.
Thank you. So I just wondering, you explained the difference between the inflation in the upper and the lower part of the lung, even the pleural pressure is same. You don't rely that...
Sorry, can you speak louder?
Sorry, you say the different inflation between the upper and lower part of the lung, even the pleural pressure is the same. What I'm trying to say is not like the transpulmonary pressure may be different.
Yes, absolutely.
And that's because the airway in the lower part doesn't open earlier. So when you reach certain pressure, you open the lower, and there will be flow from the ventilator and from the upper zone.
I'm not sure that I got your question, but you're absolutely right, because we have an absolute pleural pressure gradient which causes higher transpulmonary pressure in the upper lung. So this typically causes the upper lung to be open and the bottom part of the lung to be closed. And then if I now promote the same delta pressure in both structures, I'm expecting to see more ventilation in the upper lung, which is already open, and so has less impedance to the entrance of the gas. But I saw the opposite.
There is a difference, but what I'm trying to say is not significant difference between the upper and lower, but the reason for the difference is that because the lower alveoli is not really connected at early with the airway, with the flow. So it's closed, the airway. So it's separated from there's no gradient because of the airway closure in the lower part. When you reach certain pressure, you open the lower airway, and that will create, then you transmit the gradient between the upper alveoli and the lower alveoli.
Absolutely, I think this may be true, yes, but I didn't get your point. So do you think that this is a paradox, or you're just adding this comment?
I'm adding, but I'm saying I think that's make more significant difference than just the difference between the pleural. There is always difference between any one point and a higher point, but it's not significant to make that difference just because of the difference into the pleural pressure. I think it's secondary to the transpulmonary pressure in the upper and lower alveoli earlier in the early phase.
Okay.
Clearly, we need a chalkboard. Maybe we can go to one last question.
Yeah.
Great stuff, Marcelo. Charlie Bryan will be very happy to see this.
Thank you.
Tell me what happens when you put the patient in prone position.
That's the next talk.
No, go ahead. But yeah, we have to do next. But very likely, we are going to see a much more homogeneous thing, I believe. Let's see.
Thank you again. Our next talk is by a local Torontonian with a funny name for Toronto, huh? Laurent Brochard, who actually came all this distance for the meeting, and while he's here, he decided he would take over the whole system. So Laurent, we're really looking forward to your talk.
Thank you. Oh, that's your computer, Marcello? No, maybe I don't need to. Oh, no, I will. Okay. Okay, thank you very much. So, going to move on this issue of complex patient-ventilator interaction and focus on asynchrony, desynchrony between the patient and the ventilator. These are the companies with which research laboratory has some contracts over the last years. And this is a picture illustrating some recent ICU ventilators. And one important point here is that the characteristics of the new ventilators today is something which we markedly underuse, which is the screen and the waveforms. And I think there is a whole new semiology there, new signs that we need to learn, and which should better indicate what's really happening with the patient, and hopefully to better interact with the ventilator settings. So why should we bother? Why should we be interested about synchrony between the patient and the ventilator and look at desynchrony as something potentially harmful? There are examples where it can certainly increase the anxiety, discomfort of the patient, and maybe the dyspnea. There are other situations where it may clearly indicate that there is inadequate ventilation, and especially hyperventilation. It has been well shown that it can favor sleep disruption and therefore promote a very, very poor sleep quality, which is a major issue in the ICU. And last not least, we have several studies clearly indicating a very, very strong association between the duration of mechanical ventilation and the duration of weaning and this asynchrony. So through direct mechanism, maybe sleep, maybe poor respiratory muscle function, or indirect mechanism, maybe simply because we poorly assess what the patient is really doing. One of these studies showed a number of years ago, we showed that the patients who had a high asynchrony index were clearly those with the longer duration of mechanical ventilation. And when we look at the characteristics, we simply saw that these patients were receiving, for instance, more pressure support than the others. So you could say maybe they are sicker, but maybe it's simply because we also put more pressure support. So whether it's an indicator of worse prognosis or a cause is not demonstrated, but another study looked at this point more precisely, and in a multivariate analysis found that the presence of a high degree of asynchrony was independent predictor of a long-term, long duration of mechanical ventilation. So there may be something with better adjusting the ventilator and shortening the duration of ventilation. The term patient-ventilator interaction or asynchrony, however, includes very, very different situations. And I'll try to give you 4 examples of 4 different asynchrony with 4 different possible clinical implications. So what the interest for me is to try to link this asynchrony with the possible clinical consequences, what we should do at the bedside. And one of the most frequent asynchrony is called wasted efforts or inefficient efforts. And most of the time, it indicates that we are delivering excessive level of assist. So this was already nicely shown here, where you have the airway pressure trace, you have the esophageal pressure, and you see much more deflection on the esophageal pressure than the number of triggered breaths, which indicates that the patient's own respiratory rate is clearly much higher than the rate displayed by the ventilator. The mechanism of this ineffective effort is usually that there is a delay between the beginning of patient's own inspiration, as you can see here on the esophageal pressure trace, and the start of ventilator insufflation. This delay makes that the rest of the insufflation takes place during what is for the patient's brain the neural expiration. And this delay was explained by, for instance, a small degree of intrinsic PEEP. So when the brain of the patient commands the next breath, it arrives very soon after the end of the preceding insufflation. And therefore, there was not enough time to go back to a sufficient level of lung volume to be able to trigger the ventilator. And what you see then, these small changes on the airway pressure curve or the flow time curve, which indicate that there was an ineffective effort. The patient was doing an effort which have not been able to trigger the ventilator. And of course, this will happen especially if the duration of the preceding breath is long and the volume insufflated is high. So the higher the level of assistance, the more frequently you will see this kind of ineffective efforts. And we now have tracings of many patients ventilated for a very long period of time with a large number of asynchrony, which now you can detect even without the esophageal pressure, looking at the airway pressure and flow tracing. You have an example of pressure support ventilation and assist control. It may occur with any mode of ventilation. On some ventilators, it may not be so easy to detect. On this one, it's quite difficult to see that there is a small effort. In fact, here we have the solution because we have the diaphragmatic EMG signal, which may be a way to better detect this asynchrony. And you see that during the first breath, there is this large delay between the beginning of inspiratory effort and the delivery of the breath. And here you have an ineffective effort. Again, not obvious to say that here you have two ineffective efforts, which are, of course, completely missed by the ventilator. So the respiratory rate that you see displayed by the ventilator is not patient's respiratory rate. In this systematic analysis of the capability of caregivers to detect asynchrony, well, the results were quite poor because you have here 4 different examples of asynchrony, and they asked to experts or to non-experts, and in some cases, nobody could really detect the real asynchrony. So it may be necessary to have some monitoring of respiratory muscle function. However, if you see this asynchrony, and I show some tracings where it's, if you're used to, you can recognize, what's the best technique to avoid this asynchrony? One reasoning could be to say, because it's due to intrinsic PEEP, we could add an external PEEP. In this study, and we were a bit surprised by that, we found absolutely no effect of external PEEP. Maybe because it's very difficult to correctly titrate external PEEP. The 2 ways to reduce asynchrony were either to reduce the pressure support or to reduce the inspiratory time, which you can adjust by the expiratory threshold setting. But by far, the simpler was to reduce pressure support. And when we reduce pressure support, as you can see here, optimal pressure support, the level of asynchrony markedly decreased. It almost disappeared in all patients. There were still a few patients, probably because their respiratory mechanics were so poor, where it was difficult to avoid asynchrony. And these are the numbers which I think are quite interesting to look at. The pressure support level was initially set at 20. Why 20? Probably because we like round numbers. But when we tried to reduce pressure support, we were able to reduce down to 13. And we simply reduced pressure support until there were no asynchrony, or, of course, until the patients expressed some signs of respiratory distress. The respiratory rate on the ventilator increased, but not the real patient's respiratory rate. The question for us was, okay, we see this increase in respiratory rate. Does it indicate that the patient is making more work of breathing? And that's why we did this study to measure the pressure time product. And you see it did not change. It remained in a very normal range. And interestingly, the last point was that we went from a tidal volume of 10 to the magic number of 6 milliliters per kilogram of predicted body weight, which was the best tidal volume for this patient to reduce asynchrony. So asynchrony may indicate excessive assist. There are, at the opposite, other type of asynchrony where you may have insufficient assist. And one of those is the double triggering or the short cycles. Double triggering is, as illustrated by these two examples, occurring when the duration of patient's effort, this time, is longer than the duration of the insufflation. And you may have either, like on the right part, this weird change on the airway pressure and on the flow, indicating that at the time of the plateau, for instance, the patient is still inspiring. Or you may have this double triggering, like on the right side of the slide. So here is an example where the clinicians were extremely careful to set 6 milliliters per kilogram on the ventilator, and where the patient was receiving very frequently 12 milliliters per kilogram or even 18 milliliters per kilogram. So this is a real clinical problem to which we do not have ideal solution, but you need to try to increase the duration of inspiratory time, or increase tidal volume, or give more sedation. And in this study, it was shown, for instance, it's not double triggering, but it's this kind of tracing I show you where the patient is still inspiring at the end of the breath. It was clearly shown that the lower is the tidal volume, the more frequent is this problem. So different type of asynchrony indicating different type of response on the ventilator. Then there are even more weird, funny situations. And this one, I'm not sure. I said it may indicate that the patient is excessively sedated. It's not exactly an asynchrony. It's a patient-ventilator coupling that we very recently described and discovered, which was known to occur in healthy subjects under mechanical ventilation, and which is called respiratory entrainment or reverse triggering. So I briefly described that in another session. We found that in highly sedated patients, and it was very often patients with ARDS, the rhythm, the breathing frequency was extremely irregular. Nothing indicated that the patient was actively breathing. But at every mechanical insufflation, we found that the ventilator was triggering a diaphragmatic contraction. And you see this example where we have the EDI tracing, again, a situation where it could be useful. And it's approximately at the middle of the insufflation, every breath, that the diaphragm is contracting. For a number of reasons, we are sure that it's not the diaphragm which triggered the ventilator. It's really the ventilator triggering the diaphragm. And this is another example where on the middle tracing you have the esophageal pressure. You see it starts to increase like during a passive inflation. And then you have this abrupt contraction on the, of the respiratory muscles. And this may either make the plateau pressure completely unreliable, because at the time of the plateau, in fact, the patient is actively breathing, or this may, in different situations, increase the tidal volume set on the ventilator. This is obvious if you use pressure control, but also this may be a reason for frequent double cycling. So it's not double triggering, but double cycling. In some situation, the ventilator starts, it induces a contraction of the diaphragm, which in itself induces a second breath. So this is something which may be a dangerous situation. My last point is even more paradoxical, because I tried to convince you that synchrony was good. Well, there may be even situations where synchrony is not good, and it's better to have no synchrony at all. These are the situations where we have to compromise between protecting the lung, so delivering a small tidal volume, but trying also to keep some degree of spontaneous breathing activity. We discussed briefly about the neuromuscular blockade study. No one of us would like to give a neuromuscular blockade for a large number of days. So even it may be interesting at the beginning, and we should understand better why, we need to put the patient under spontaneous ventilation. However, spontaneous ventilation may amplify the transpulmonary pressure swings already induced by the mechanical ventilator. And this is just an example where this was initially a bench study. We use exactly the same pressure settings on the ventilator with different kind of modes. All are pressure-targeted modes like APRV, BiPAP, pressure control. So exactly same pressure settings and exactly same simulated patient's inspiratory effort. But on the first row, you have no synchronization between patient's effort and the ventilator. In the middle, you have a partial synchronization, like during SIMV. And on the right, you have a full synchronization, like during pressure control. And we found clearly that the more synchronization compared to the initial setting, the larger the mean tidal volume, and the smaller was the variability. So this was on the bench, but when we repeated experiment in patients with variability between patients, in general, we found the same. And this again may be a non-desirable situation when you think that lung protection is still very important, and using a non-synchronous mode like APRV, which we used here with completely standard settings. It was a short inspiratory time and a long expiratory time. But APRV has the specific characteristics of being completely non-synchronized with patient's effort. So in this situation, it may be the best solution to compromise between some degree of spontaneous breathing and preservation of lung protective ventilatory strategy. So in summary, I think we have a lot to learn in this field. The tool we have today is the screen and the waveforms. There are situations where having an additional signal like esophageal pressure or EDI will clearly be helpful. We'll need training and education, and the interesting point for us clinicians is that asynchrony often indicates inadequate assist. Excessive assist in case of ineffective efforts, which is the most frequent asynchrony. Insufficient assist or short insufflation in case of double triggering. We are not sure yet for the entrainment and reverse triggering, and we don't know exactly the incidence of this problem, but it may indicate clearly an excessive level of sedation. So with this, I stop there and be happy to answer any question. Thank you.
We're open for questions. While we're waiting, can I just ask, I mean, you mentioned education is very important, and it strikes me that the physician is there not all of the day. You're not there all night, and so very significant asynchrony can occur. How are you approaching educating the team to deal with this, and how's that going?
Yeah, so once you're a little bit trained to try to capture this deformation of the curves, once you see it, it's obvious that, for instance, in effective efforts, to see that the patient is, you look at the patient, you look at the ventilator, and then you realize that the patient is yes, doing much more effort than what you see on the ventilator. The clinical issue is then, if you reduce pressure support, you may well synchronize the patient with the ventilator, but then the respiratory rate will go up on the ventilator from 15 to 30 per minute. And the question for us was, is it safe to keep the patient in this situation? And that's why we measured the work of breathing, to be confident that, in fact, the patient was doing approximately exactly the same work. So it does not completely address your point, but the first teaching is to say, if you see that, you change the pressure support level or adapt something else. Don't be afraid of seeing this change of respiratory rate on the ventilator. The next step would be to have more information of what the patient is really doing, and therefore having a continuous monitoring of diaphragmal electrical activity or esophageal pressure.
Good. I'm not seeing any questions out there. Can I just ask one more, which is, the ventilators are all coming out with pretty good displays, frankly. Is the availability of the display changing practice as far as you can tell?
That's a good question. We don't have a lot of data about that. There was one nice, relatively small but quite good randomized control trial during non-invasive ventilation, where they compare the efficacy of non-invasive ventilation if you have a good screen showing the different waveforms, or if you don't have a screen and just the numbers. Mm-hmm. And no outcome data, but in terms of efficacy for improving gas exchange, reducing dyspnea, it was much more efficient with the screen. So we probably need more data on that, but...
Good. Thank you, Laurent.
So this afternoon you've heard about the interaction of the lung and the ventilator, and that was very nicely demonstrated by Marcello. You've heard about the interaction of the patient and the ventilation, and this afternoon we're now going to hear from Laura Shekerdemian about how the heart and the lung interact during ventilation. Laura trained in London initially, London, England, and then spent some time with us here in Toronto at Sick Kids before going on to Melbourne. And she's since come back to North America, where she is in charge at Baylor College of Medicine of Critical Care. Laura.
Thank you very much, Peter. Could I have my slides, please? Yeah, is there anyone that can help connect my, mirror my slides? Thank you. It's off. I think it's because someone else used it. He's got to switch. There was. Yeah, he's there. Yeah, perfect. Thank you very much. Good afternoon, ladies and gentlemen. It's wonderful to be here, and thanks so much for the organisers for asking me to speak today. I guess we're going to switch gears a bit. I'm a paediatric intensivist, and I've done quite a lot of work with children with congenital heart disease. So we see some very, very interesting heart-lung interactions in our paediatric cardiac population. This is a study here that's quite historic now from adults with ischemic heart disease, showing very nicely how they can get some very marked perfusion defects after extubation in the presence of ischemia. So this is from discontinuation of positive pressure ventilation. And why is it that that patient will do badly, and potentially these patients will do very well on extubation? This is a nice study, a very simple study showing near-infrared spectroscopy measurements on extubating a population of children after tetralogy of Fallot repair in the pediatric cardiac ICU. So what I'm going to talk about in the next few minutes is really how we can explore heart-lung interactions in children with heart disease, and how we can put these into practice, and really using ventilation and respiration to optimize hemodynamics in this population. So clearly, before launching into the kind of complex and unusual circulations that we so routinely manage, we've got to remember the basic principles. They apply to our patients just as they do to adults and those without structural heart disease. Mustn't forget about the effects of intrathoracic pressure and right ventricular preload, left ventricular afterload, and the right ventricle, left ventricle interactions. And clearly, some of our patients also have heart failure, and important interactions exist in these patients. I'll go back even further than the comments our moderator made earlier about Dr. Bryan's early experiments. Back in the 1940s, after the war, André Cournot really kind of paved the way for physiological studies in looking at the physiological interactions between the heart and the lungs. Very much like Dr. Bryan and his team, he invaded very heavily some healthy adults with intrapleural, intracardiac, and various other catheters, and really established what we now use as a very, very sort of standard management to approach in our patients. What Cournot found in his patients, that depending on the mean airway pressure and components of mask-positive pressure ventilation, he could alter cardiac output by as much as a reduction of 15% in some settings, whereas with a shorter I time and a lower mean airway pressure, cardiac output was relatively well preserved. And because he was able to get some beautiful recordings from his invasion of his healthy co-workers, he managed to establish very nicely that these effects in healthy individuals were primarily due to effects of positive pressure ventilation on right ventricular preload. More recently, some work from the Toronto group who've really paved the way in the modern era, I think, for the heart-lung interaction work, comes some observations looking at patients with heart failure who were asked to do a Muller maneuver. And a Muller maneuver is making a very negative intrathoracic pressure by inspiration on a closed glottis. And what Dr. Bradley's group showed here was that, as we would expect from what we know now, with a very excessive negative intrathoracic pressure, the stroke volume index would fall in the left ventricle. This is in patients with heart failure. The transmural intraventricular pressure would increase, together with a very negative fall in esophageal pressure, and quite a dramatic fall in cardiac index towards the end of the cardiac cycles during those maneuvers. Positive pressure ventilation is good for the left heart. It's good for left heart dysfunction, and it works by reducing the afterload. There's many, many trials in the literature looking at the impact of positive pressure ventilation by non-invasive means in adults with congestive heart failure presenting in the emergency department. And this is just one of those studies from Dr. Amato and his colleagues. And really it shows us very nicely what we would expect is that early initiation of non-invasive ventilation in patients in severe heart failure will reduce the intubation rate. Not only would it do so, it would potentially reduce the early mortality as well. Now, we struggle a bit when we're applying all this to children with heart disease. There isn't a great deal of work, but clearly the principles I've described to you should apply. Non-invasive ventilation in children with heart failure should reduce their work of breathing, potentially reduce their LV afterload, improve their FRC, and certainly reduce intrapulmonary shunt, and hopefully reduce their need for intubation. The routine use of this therapy in children is really underreported, although it's pretty well anecdotally explored. And the role potentially in children would really extend to the heart failure population, and potentially elective use early after extubation after cardiac surgery. There's one paper in the literature that was published relatively recently looking, this is from the Stanford Pediatric Cardiac Group, looking at the impact of prophylactic extubation to non-invasive mask ventilation in children after cardiac surgery. It was 221 episodes in around 200 patients. And what they found was that prophylactic use of CPAP or BiPAP seemed to reduce ICU length of stay, and that it was more likely to be successful, as I've shown here, in patients who had been intubated for less long. The so-called responders were likely to have less complex heart disease, were more likely to have intrinsic lung disease at extubation, which obviously would benefit from ongoing positive pressure, and better cardiac function, and that's really not rocket science. It doesn't seem overly surprising. What surprised me from this population in a busy cardiac unit was that only about 1 in 10 of those patients actually had medical cardiac disease, in other words, cardiomyopathy, myocarditis, and that potentially would be a more interesting group to study. So I'm going to move on from the structurally normal heart to the less conventional circulations that those of us that care for children with congenital heart disease encounter every day in the cardiac unit. There's 4 groups of patients I'm going to go through in the rest of this talk. Patients after stage 1 palliation or Norwood type operations for hypoplastic left heart syndrome. Patients who undergo bidirectional Glenn with a cavopulmonary anastomosis from the SVC to the main pulmonary artery. Patients after tetralogy of fallow repair who have a corrective cardiac operation resulting in separation of the circulations. And patients who've had a Fontan operation who have a palliative separation of the systemic and pulmonary circulations without a functional subpulmonary ventricle. I think those of us that have looked after patients with hypoplastic left heart syndrome for more than 10 years will have seen a huge change in the evolution of perioperative care, particularly how we manage their ventilation and blood gas management. This very elegant work from the San Francisco group back in the mid-90s looked at the different impacts of different additional gases on pulmonary blood flow in this population. And this was a population of lambs that they created an in utero model of hypoplastic left heart with a shunt. They delivered them, placed them on bypass, and restudied them. So they used pulmonary vasodilators, nitric oxide, and 100% oxygen. And then they used hypoxic gas mixture with supplemental nitrogen and supplemental carbon dioxide. And what they found were very significant reductions in QPQS, which is what we used to aim for. We used to aim for a reduction in pulmonary blood flow in these patients, whereas when you give pulmonary vasodilators, no surprises, the pulmonary blood flow will go up, interestingly, much more with 100% oxygen than it does with inhaled nitric. Over the next few years, people thought a lot harder about the best way to ventilate these patients. And one of the problems we have in intensive care in many, many units, although sick kids do some very, very impressive monitoring in their Norwood patients, is the assumptions that we make when we're thinking about QPQS. And this work here, which was from Cincinnati when Steve Schwartz was there, he's now at Sick Kids, actually looked at the impact of these assumptions that we make on estimated versus true QPQS. And what you find is a huge variability in what the real QPQS is according to the true pulmonary venous saturation. So the impact of the true pulmonary venous saturation on our measured QPQS is huge, and it's obviously a number that very few of us have access to. What I think is very interesting from this paper is the impact of very modest increases in inspired oxygen on the oxygen extraction ratio. In the 1990s, the early 2000s, we really didn't go much above 21-25% oxygen in these patients. But this group showed very nicely how you can go to 50% oxygen, actually improving the oxygen extraction ratio and most likely systemic oxygen delivery. And if you just create a small table out of some of these assumptions, if the facts are for a given patient that the arterial saturation 80%, the mixed venous is 50%, and the pulmonary arterial oxygen saturation, obviously the same as systemic because it's a BT shunt, will be 80%. If we assume 100% oxygen, the calculated QPQS is 1.5 to 1. Take that down by 10%, and you'll double the QPQS. So see, there's some of the very, very significant pitfalls we used to come across when we used to very, very enthusiastically assume and measure the QPQS after surgery. And this table I've put here really just shows how our practice has evolved so much over the last decade or so. Back in the 90s, when I was a fellow, we used to do all sorts of very, very aggressive interventions on patients. It was great practice for us as fellows, and junior faculty, but probably quite damaging to the patients. All our Norwoods would get intubated preoperatively, even if they were lying very comfortably on prostaglandin. And we used to measure their blood gases almost every time they turned, every time we looked at them, just so that we could make sure we were balancing the circulations properly. We used to have tables saying what the ratio was every hour or two. We used to control their QP by allowing mild acidosis on the ventilator. We avoided supplemental oxygen, gave a lot of nitrogen to them, probably reducing their systemic oxygen delivery without realizing. And we used to give sometimes supplemental CO2. Nowadays, we're very hands-off with careful observation. We optimize their systemic oxygen delivery. We're much more liberal with inspired oxygen. We aim for a normal pH and a normal CO2. The only thing we avoid is alkalosis. And really, the use of supplemental gases is almost obsolete. We don't have nitrogen or CO2 available in our unit. So I'm going to move forward with the single ventricle population, looking now at patients after Fontan operations. So why could a patient, a child with such good systemic ventricular contractility, look so sick on an ICU? I think those of us that have looked after Fontan patients will know that the occasional patient can look terrible despite having a great systolic function of their heart. One of the very interesting observations that Fontan made from his original paper looking at 3 young adults in whom he performed quite a complex version of what we've simplified over the years for tricuspid atresia, he actually recommended, just as I've shown here, that respiratory assistance should be stopped early because positive pressure prevents central venous return. And what we now know from work in the early 1990s from Dan Penny and Andrew Reddington back in London was how critically important changes in intrathoracic pressure are in determining the pulmonary blood flow of Fontan patients. What you can see here from a spontaneously breathing patient is blood flow to the lungs on Doppler here below the solid line, and how exaggerated that becomes with spontaneous inspiration and almost stops during expiration, and also how unrelated it is to the ECG, which is shown at the top. A few years after that work was done, I did some research back at the Brompton with Andrew Reddington, look at the impact of different types of ventilation on Fontan patients. These were the days where we didn't routinely extubate these patients on table, which we've all learned since is probably the best thing for them. So in a group of children after Fontan operations who were receiving relatively modest levels of conventional positive pressure ventilation, we did a series of echoes. This is a transesophageal Doppler showing pulmonary arterial flow above the line here. And you can see it's completely attenuated, potentially even reversed during positive pressure inspiration. And then it's maintained back during expiration. And then what we did with these patients was place a negative pressure cuirass, delivered negative pressure ventilation to mimic spontaneous respiration. And with that, we saw a big exaggeration of forward pulmonary blood flow just with the institution of that modality. And what we found was an increase that you're really not going to get with any drugs in this day and age, was that a period of negative pressure ventilation could increase their cardiac output by around 50%. We also looked in detail at patients with tetralogy of Fallot repair. Now, a subgroup of these patients does get significant diastolic dysfunction early after surgery. And what we know from work, again, that was done in the mid-90s back in London, is that a subgroup of patients has very classic restrictive right ventricular physiology. And what this means is that there's effectively premature opening of the pulmonary valve here, which is brought about by an increase in diastolic right ventricular pressure coincident with atrial systole. So here we have the ECG with a P wave. The right ventricular pressure trace has a bit of a peak there. And the pulmonary arterial flow goes forward during late diastole. This is the hallmark of restrictive RV physiology. And what Shay Cullen showed in his first paper on this was very interesting sort of differences in the post-operative course on the ICU in the 2 patient groups. Around a third of these kids had restrictive physiology. They had lower blood pressure, poorer urine output, all the signs that we're very familiar with now of a low output state. So taking this one step further, he looked at the different flow patterns in the pulmonary artery and transtricuspid flow of these patients and showed that during conventional positive pressure ventilation, during inspiration, there's a significant reduction in this in the trans-tricuspid inflow. And you see these waves here, which are that the hallmark of restrictive physiology. They disappear during positive pressure inspiration. So taking that one step forward, no prizes for guessing what we did. We looked at the impact of negative pressure ventilation in these patients. And very similarly, just like the Fontan patients, found that just by preserving forward pulmonary arterial flow throughout the respiratory cycle and exaggerating it during inspiration, we were able to increase the cardiac output. Now, we're not suggesting for a moment that this should ever become a routine in our patients, but I guess what has evolved from work that's probably 15 to 20 years ago now is the fact that these patients all benefit from breathing for themselves. And that's really our post-operative goal in the majority. And the last group of patients I was going to talk about are those with a single ventricle physiology after bidirectional Glenn operation. So these patients, again, don't have much of a forward pumping chamber to the lungs in terms of a right ventricle. They rely on passive pulmonary blood flow from the SVC to the pulmonary arteries. There's some very elegant work that's come from hemodynamic studies from sick kids here, looking at how blood gas management and ventilation can be used to tune up the systemic oxygen delivery of these patients with cavopulmonary shunts. And the interesting thing in these patients is that we're trying to balance cerebral blood flow. Kids under 1 have a big head, they've got a much higher relative flow to their brains and systemic and SVC drainage than we do as adults, versus pulmonary blood flows. Everyone in this room knows that the impact of pH and PCO2 will be the reverse in the lungs versus the brain. And what the Toronto group found, I think this is a beautiful study, very simple. They just showed the impact of increasing CO2 by adding CO2 to the ventilator gas, how it impacts on systemic arterial oxygenation, on SVC saturation, and on cerebral near-infrared spectroscopy. So all these parameters got better with a higher PCO2 than normal, and that would translate into a pH of sort of 7.25 to 7.3. And these very simple studies, which are backed up by some further, more detailed work from the same investigators using mass spectrometry, showing that the VO2 actually is at its best with a higher CO2, slightly lower pH, and obviously aligned with the improved systemic oxygen delivery. I think this has shaped the way we all approach ventilation in this patient population. And in this group and patients with tetralogy of Fallot, I think I've emphasized the importance of allowing spontaneous breathing wherever possible, or at least some spontaneous inspiratory effort. We've heard some amazing talks about the interaction between spontaneous breathing and the ventilator in adult populations with different types of cardiopulmonary injury, I guess. And again, from sick kids here, this paper has looked at APRV, which is in pediatric practice a very new mode of ventilation that in most units is confined still to patients with severe ARDS-type lung injury. But this study was in patients after tetralogy of Fallot repair and patients after a Glenn operation, so bidirectional cavopulmonary anastomosis. And these patients are conventionally ventilated to start with, and then they're placed on APRV for a period of time, and they have direct fit cardiac output measurements, which most of us can only dream about. So you see here two very typical recordings here during pressure-controlled ventilation. Sorry, these are the wrong way around, and APRV. And showing with the APRV with obviously very short periods of pressure drop, and also allowing spontaneous breathing without pressure assistance during those moments. But the interesting findings here are how the pulmonary blood flow and therefore cardiac output of these patients is better on APRV. Systemic oxygen delivery is obviously going to be better, but at a slightly higher airway pressure, although that didn't achieve significance. And again, I think that shows that in some patients with such sophisticated cardiopulmonary interactions, that it's not just about airway pressure, it's about the importance of allowing some spontaneous respiratory movement. So really the point is in a lot of our patients towards the importance of early extubation and really aiming for this wherever possible if it makes physiologic sense. We're still a long way behind the adults in this practice, although there are some groups that are actually very aggressive about this. The group in Sinai have published a lot of work in their congenital heart population, showing an overall 4 in 5 patients are extubated either on table or within an hour or two of arrival in the ICU. And that includes relatively complex patients, children after Fallot's repair, even patients in young infancy with atrioventricular septal defects. And that's with a very low reintubation rate, so it can be done. And one of the studies that some people in this room will hopefully be entering into alongside us, funded by the PHN, is going to be a collaborative learning study which actually looks at the introduction of a clinical practice guideline aimed at early extubation after cardiac surgery. So in summary, the heart and lungs in children with heart disease, there's unique cardiopulmonary interactions that are very different to those which most adult intensivists will encounter. But hopefully I've shown you that this can be used as a very, very useful and valuable hemodynamic tool to optimize pulmonary flow and systemic oxygen delivery. And finally, ventilation for all of us can be our friend or our foe. Thank you very much.
Thanks very much, Lara. I remember being in the era where we used to give patients routinely 5% CO2, and this was based on the philosophy of how it affected pulmonary vascular resistance. What's interesting by doing repeated measurements is that you've been able to show that if you use a ventilator appropriately, you can actually get benefit, but inappropriate use will lead to harm. So I'm going to ask you, what has happened with your work with negative pressure ventilation?
I haven't used a cuirass since I left England, probably in 2001, and I hear anecdotes of people every few years who've used it on one patient. I think the main thrust of our work was just to reinforce everybody's gut feeling and understanding of physiology to that point of how important it is to just get the tube out. And I think we've all stood there with a Fontan patient who's looking grey and their lactate might be 3 or 4, who's, for us, unusually come out of the OR it's still intubated. And we say we've got to bite the bullet, take the tube out. And 19 times out of 20, it will be the right decision. So I think it's just helped us understand the importance of just being aggressive early, as long as we understand the physiology.
Good, thank you. Des?
Thanks, Lara. Very elegant as ever. So I totally agree with everything you say about single ventricle and how we sort of maybe obsessed about balancing QP-QS in the past. So what do you say to people who use pulse oximeters to say, to make comments on QP-QS? Because I still think there's an obsession about saying, well, if the pulse oximeter is reading 90%, the patient's over-circulating. So how did you deal with that situation?
I think it's just one of many numbers that we look at. In the preoperative hypoplasts, we often see SATs in the mid to high 90s. And when a child has that, is otherwise, whatever markers we have of systemic perfusion are okay, we ignore it. If the child starts to get tachypneic, anything else changes, it's time for surgery. In the post-operative setting, we are much more tolerant of higher saturations, especially in the day now where we're all much more liberal with systemic vasodilators. Mm-hmm. So, and I think there's some nice work from Milwaukee and I think from a group in Japan who show that really you can tolerate very high saturations if you have either an alpha block patient or a patient who's on decent doses of systemic dilators. So it's really a number that I think for many of us has become less important, but if it's climbing in a child who has other signs, and I know in Toronto they're very keen on measuring systemic vascular resistance, I think in that context it's a worry. On its own, it's just another number, I think, now.
Right. Thanks.
Okay, no more questions?
Sure. Go ahead. Just do this quickly. Our next speaker is Shelley Magder from McGill, Montreal. And I first met Shelley actually when I was an intern. It was my first day in the intensive care unit. And within 10 minutes of the patient being assigned to me to look after, my patient arrested and died. And I suppose, well, it said a lot about my career, but I suppose that would have been the end of my career as an intensive care physician, except to talk to Shelley afterwards. And he, things like did you notice how the arterial pressure fell and the venous pressure rose? Did you notice that they came to the same value? What do you think that means? So I was right back in there in the game. So Shelley, maybe you can put us right back in the game.
Well, I'm going to go over some principles that may help us with understanding some of the things we've been seeing in the last few talks. If I make sure I got this right. Yes. I thought I would just start off with something, though, which really is, well, actually, I'll start off with this as a basic approach to heart-lung interactions. They really are quite complicated. However, you really could simplify it down to thinking of spontaneous versus positive, right left ventricle versus left ventricle. But a few points really count. And for today's talk, it's really going to be about positive pressure, and most of the action is on the right ventricle, both in and out, actually. I only have in there, but it'll also be out. So I just wanted to get rid of this one small artifact, but it was a fun one because it created a lot of confusion back in the 70s and into the early 80s. And the question was, does positive pressure itself depress cardiac function through a central neurogenic type mechanism? Because what you would often see is that you would have a lower right atrial pressure with a lower cardiac output. So it would look like the cardiac function curve went down. However, that was only one point. And I just want to show this one because it's a classic study by John Marini during his training with Culver and Butler when he was still in Seattle. And what they did is they just very carefully looked at the pressure around the heart so they could get the transmural pressure. So this would be the observation at first, that it looks like the stroke volume is moved to the, is this going to work? Oops, didn't want that one. How do I go back? Oh, I see. Okay, there's no pointer on this. Okay. So if you look at the top tracings, is there a pointer? Sorry. Or can I get into it?
Control A. And that, with a little bit of luck, gave you a pointer.
Except that's not my slides.
Whoops.
Yeah.
That wasn't a good thing to do.
Yeah, that's not my slides. Okay.
I'll let you.
I don't know how I can find mine. Can I get? It's not on there. Okay. All right. All right. Sorry about that. And if I can just find, yes. So looking at this top one, this is the left atrium and left atrium, right atrium, and then what he's showing is this would be the pattern that you would see. But if you corrected for the outside pressures, the curves are perfectly superimposable. So this was just an artifact of the way you made the measurements. And there is no neurological effect, sympathetic effect on the heart from breathing itself. Okay. So I'm sorry, I'm getting a little challenged here. So the real point I want to make today and emphasize is the importance between the changes in pleural pressure and changes in transpulmonary pressure or lung inflation. This started with a discussion I had with Jardin from France and Villard-Baron on what is the cause of pulse pressure variations. And I had argued that it was primarily the changes in pleural pressure, and they had argued that it was primarily the changes in transpulmonary pressure. So that started off a long debate between us and led to the data that I'm going to show you. Well, just going on historically, let's start off with changes in pleural pressure, because this is definitely easier to understand. So just to remind people about venous return curves very briefly, we look at the relationship of blood coming back to the heart related to the recoil pressure from the peripheral veins back to the heart. And then we have a cardiac function curve, and we put the two together to understand the relationship of the return of blood to the chest and the ability of the heart to pump it out. And where they intersect gives you the working right atrial pressure and the working central venous pressure for these two functions. So for this part of the discussion, we'll assume that the venous return curve stays the same, that we haven't altered that, which is at least true over the short run as we look at heart-lung interactions. So the primary thing that is going to be happening is that as we lower the pleural pressure, we lower the reference point of the heart relative to the rest of the body, as in that John Marini study. So you'll notice that this curve starts at a 0 value. And that's because the heart at rest, in us sitting here, is slightly negative relative to the rest of the body, because at FRC, your pleural pressure is slightly negative. The chest wall is pulling out and the lungs are recoiling in. So with a spontaneous breath, as we were looking at in the last pediatric studies, your heart is becoming more negative relative to the rest of the body during a breath. So you have a fall in right atrial pressure and an increased filling of the right ventricle under normal circumstances. So let's go to the positive pressure side. So that would also be true in a triggered breath on a patient on a ventilator. That same phenomenon would happen, and that's why as you get more spontaneous, as we saw in the tetralogy of Flo and the other kids, that you are getting that benefit of the increased filling of the heart. Now, on positive pressure, first of all, we make the heart more positive relative to the rest of the body. So we now shift that curve to the right, which would cause a fall in a rise in right atrial pressure and a fall in cardiac output. And now when we breathe from that point, then at each breath it becomes worse with our positive pressure. So on each breath, we're decreasing the filling of the right heart transiently during the breath. Now an interesting thing happens when you're doing this on the plateau of the venous return curve. When you're on the plateau of the venous return curve, when it's flat, now when you take a breath and you're moving on the positive side, at least from the position I have here, you can have a possibility of an increase in, of the pleural pressure changing without a change in cardiac output. Now clearly if I go farther, I'll reach a point where there will be a fall. What does happen though, this is the transmural pressure for the heart. So when we applied this positive pressure and moved the heart to this side, we've now decompressed the right ventricle. The transmural pressure has gone down. So that reduced diastolic wall tension is actually giving less what I call wasted preload. And as we all know, this is one of the benefits of a patient in heart failure. You put them on positive pressure, we decompress the right heart. Now, as I said, if the pleural pressure is large enough, you will again decrease the cardiac output. So we actually put this together. Oh, I don't know if I got here, sorry. Another important effect of a positive pressure is when we move the heart to the right, we also change what's called the collapse pressure. So over here you can see as we lower right atrial pressure further, there's no change in cardiac output because the great veins collapse as they enter the thorax and the pressures are less than atmosphere. But when we apply positive pleural pressure, that collapse point occurs at a positive value instead of the negative. What that means, this is the maximum amount of blood that can come back. So changing cardiac function when you're on the flat part of the curve cannot actually change cardiac output anymore. You can only change cardiac output by filling the heart up more. So it creates what's called a vascular waterfall, and then you're dependent upon volume to actually increase your cardiac output. So at high levels of PEEP, and as you increase pleural pressure, this becomes very important because it's a limit to actually how much you can fill the heart. Now, why are changes in right atrial pressure so important and affecting the output? Because the gradient for venous return is so small. It's only in the range of about 4 to 6 millimeters of mercury. So if you increase pleural pressure by 6, you would actually transiently stop all the return to the heart. So we actually asked whether we could use swings in right atrial pressure to predict the response to PEEP. So I previously published how swings in right atrial pressure can predict response to fluids. So we wondered whether it would predict the response to fluids, to a PEEP. So this was the rationale in that study. So first of all, they had to have a triggered breath with an inspiratory effort. And in those studies, we actually looked at the change in pleural pressure as assessed by a change in wedge. So this is an example of somebody who has a change in pulmonary artery occlusion pressure, and you can see at the same time no change in right atrial pressure. Maybe these little increased Y descents tell you the breath, but this baseline is perfectly flat. So this person, as I'll show you, would be on the flat part of their cardiac function curve. And that's illustrated here. Here's the venous return cardiac function curve. On a normal breath, this should go to the left. So if you're on the ascending part of your cardiac function curve, you should have a fall in right atrial pressure with the breath. And that person, when we added PEEP, we would expect would probably have a fall in cardiac output. On the other hand, if you're on the flat part of your cardiac function curve and you take a breath, you have no change in right atrial pressure, as in the example I showed you, and you would predict that that person might not have a fall, depending upon how much you shifted the heart. So the argument would be that these should always have a fall in pleural pressure. These may or may not, depending how much you applied. Well, it sort of worked, but not quite. And I'll show you what happened. So this is the result. So these are the ones that we expect should have a fall. And a lot of them did, but not all the patients. And on the other hand, we predicted that these would not have a fall. and some still did. So, but that was okay, because we said if the pleural pressure was high enough, this would be expected. But we thought this might do a little bit better, and we were surprised that some didn't. And the reason is this is over time, and you have reflex adjustments, and you contract your capacitant bed, and you can actually overcome it. So when you were looking at a spontaneous breath and looking for a fluid challenge, that's not a problem, because that was instantaneous. But now this is over time, and you can adjust. And the type of adjustments occur through contraction of vascular capacitance. This was in an animal study that we did to demonstrate this. So this looks at mean circulatory pressure and blood volume, and this is cardiac output and CVP, or right atrial pressure. So, but application of PEEP, we actually were able to get venous return curves and pressure volume curves. So with the application of PEEP, you get a shift to the left of the pressure volume curve. So you recruit unstressed into stressed volume. And a higher level of PEEP, up to 20, then we get a further shift. And that also, at the same time, shifts the venous return curve to the right. So more PEEP, a higher value, and again, the venous return curve shifts to the right. And so if we put that together with cardiac function curves, what happens through this process is your cardiac output would fall dramatically with the PEEP, but because you're able to compensate with the shift in the venous return curve, you can restore a lot of that cardiac output. But you have to have the volume reserves in your system to be able to do that. Okay, so what about changes in transpulmonary pressure? So this is a little trickier, actually. And this is where the debate with Brochard, Baron, and myself began. He argued from his echo studies using Dopplers that if you look at, so this is a Doppler of the pulmonary artery, and this is the tricuspid velocity. And he argued that the pulmonary artery flow velocity went down before the tricuspid. So if you look at 1, 2, 3, 4, and then the next one below, 1, 2, 3, 4, he's arguing that this drops before this one, which, in other words, you're having less going out than in. But these are very tough. Think of the frequency response of the heart, the frequency response of breathing, where you're timing, the frequency response of the Doppler. But he does enough of these, and he's got some convincing evidence that it might happen. But I think I actually have a reason why it might, and I'll show you that. So it has to do with how, oh, before that though. On the other hand, I was rather skeptical that this could be important. And this is an old study by Culver, John Marini again, and Butler, who did some great work back at that time. And what they've done on this is a complicated slide, but what they show here is, first of all, airway pressure. And then they have arterial pressure. And this shows the pulmonary artery pressure and the left atrial pressure, which was directly measured in these animals. And then right atrial pressure. So when they apply PEEP, you could see there is quite a dramatic decrease in the arterial pressure with a moderate rise in pulmonary artery pressures. But then what they did is they then just banded the pulmonary artery, which is on the other side, and looked at the effects of banding a pulmonary artery, and now you can see there's actually quite a small fall in arterial pressure for a huge change in pulmonary artery pressure. So you wouldn't expect by itself that load on the right heart to be that important. Now these are normal dogs. Okay, but how does change in pulmonary artery, lung inflation affect the right heart? Well, this, actually, sorry, I'm a little bit off again. Trying to look, separating out this change in pleural pressure from change in lung inflation was really nicely done by the study by Stephen Scharf. It was a very elegant study. So what he tried to do is look at, first of all, everything, transpulmonary and pleural, and then just the pleural part. So first of all, looking on the left part, so he just does a lung inflation. And as you do that, the pleural pressure goes up, the transpulmonary pressure goes up, and volume goes up. Nothing surprising. So now what he does on the other side, he hooked the airway pressure up to the pleural space. So now when he actually increased the pleural pressure, it also increased the airway pressure, it increases pleural pressure. So now what happens, you have no change in lung volume, you have a change in pleural pressure, but no change in lung volume and no change in transmural pressure because the airway is immediately transmitted to the pleural space. So we can look at the hemodynamics under these two conditions. So in the first one, which would be a typical breath with pleural pressure and lung volume changes, what you could see is you get the marked fall in cardiac output and the rise in right atrial pressure, but when he does just keeping the transpulmonary pressure constant and just changing the pleural, he still actually gets this almost the same fall in cardiac output. So I've always argued that this says to me that the change in pleural pressure is the more important variable. But the argument still went on with myself and Jourdain, Voyard, Baron. And began to think, so I wanted to try modeling this in a computer study. But I was trying to think of how does lung inflation actually affect the load on the right heart. And what it does do, it does not change resistance. That concept has been out there, but it's just been wrong, but it's consistently out there. What it does do is it changes the outflow pressure, or zone 2 conditions. And that's illustrated here. So if we start off with expiration, some pressures, let's say 0 in the alveolus, 6 in the left atrium, and 20 in on the pulmonary artery, let's say. And similar numbers, but a little lower left atrial pressure on this one. So now I inflate the lungs. So on this side, as I inflate the lungs, let's say I create a positive pressure of 10, and 5 of that's transmitted to the pleural space, and this went up to 11 in this person. Well, they would still be in zone 3 conditions. The alveolar pressure is less than the left atrial pressure, and we have no compression here, because fluids are not compressible, essentially not compressible. But on this side, depending upon the starting conditions and how loaded the atrium was, I now have pulmonary alveolar pressure is greater than left atrial pressure, and I've created zone 2 conditions. And when that happens, then the alveolar pressure becomes the outflow pressure for the right ventricle. So every increase in alveolar pressure at that point is a direct increase in the load on the right ventricle. Okay, so we tried to do this in a computer modeling study. So I could, with a model, I could actually separate all these one by one. So what it shows on the left are the compartments I use, which is a right ventricle, an a pulmonary artery compliant region, a pulmonary venous compliant region, a left ventricle, a systemic artery compliant region, a systemic venous compliant region, and back again. And the model has a series of compliances and resistances and a time-varying elastances for the ventricles, so all this functions like a normal ventricle. And then we did it 2 ways. So for pleural pressure, that was really easy in the model, as all I had to do was raise the pressure in all the compartments that are inside the chest. Lung inflation was trickier, but actually once I realized that it was the outflow pressure, it actually became easier. In fact, it was kind of funny. I actually called up Saul Permit to ask him, what's a good number to use for the change in resistance? Because that's what I thought I was going to do. And of course, the response I got, it's not the resistance, dummy, it's the outflow pressure, which I should have known because he's the person who described it. Anyways, so what I did is I apply a mechanism in the computer program that when the alveolar pressure is greater than the left ventricular diastolic pressure, then that becomes the outflow pressure. Now, the assumption here, it's like taking an isolated lung. So that means the chest, all the things in the chest are surrounded by atmosphere now and no pleural pressure. So it'll be like I had an isolated lung. So in that case, the alveolar pressure is the same as the transpulmonary pressure because it's from alveolus to atmosphere. All right, so this is the model, which I won't go through, but it actually is not that difficult. It's in MATLAB and Simulink. So first of all, we just made a static increase in inflation pressure. So this is increasing pleural pressure steadily from 0 to 16, and looking at the calculated flow in the model. And you can see by the time we get to about 12, the flow is essentially 0, and the model crashes, actually. If we're looking at, on this side, this is the arterial pressure, which is going to fall because it's directly related to flow. And this is actually giving me the mean circulatory filling pressure, which is rising as I'm backing fluid up into the large venous compliant region. But now if I increase alveolar pressure, or transpulmonary, at first nothing happens because I haven't created zone 2. Now you have to realize the way I've done the model, zone 2 becomes the whole lung. I can't do part. But you could just modify it, and then it would be if there was less. So this is giving if the whole lung became zone 2 conditions. So at first nothing happens, but once I have zone 2 conditions, as I increase alveolar pressures, I then eventually get to 0 flow, but you have much higher values before you actually have that effect. And here again, the arterial pressure is falling, but what you'll notice here is the mean circulatory filling pressure is falling. And that's because the right heart is working, and it doesn't fail because it's a computer model, so it can handle the high pressures, and it's now displacing peripheral volume into the chest, and the pulmonary venous volumes are going up. Now, then we switch to a dynamic model, so now it's breathing, and we're breathing at a rate of 10 per minute. And what you see is as you increase the pleural pressure, you get this fall, but then even though I'm going to higher values, nothing else happens. And I'm going to show you why that's the case in a moment. Same thing on the pulmonary, transpulmonary pressure. Nothing happens at first because you have to hit the Starling resistor. And then even though I'm at very high values, it doesn't affect what's happening. If we look at, here is the change in mean systemic, let me get the right one, sorry. Yeah, so here is pulmonary venous pressure, which is, pulmonary venous pressure or capillary pressure, which is falling with the rise in pleural pressure at the same time as mean circulatory pressure is going up. But, as I mentioned before, if I change transpulmonary pressure, then the pulmonary venous pressures rise because the obstruction is downstream from the pulmonary, capillary, and then venous region, because that's the most collapsible. So the reason why nothing is happening during the breaths is because what I've called pulmonary vascular reservoir buffer. So with this model, I'm able to look at pressure volume loops of the right and left ventricle during the breaths. So these are simulated. These are all made up data. So you'll see what happens in the right ventricle during the breath. So here's the counting. This is the pulmonary artery, and this is the arterial side. This is right ventricle. This is left ventricle. So you could see during the breaths, I just counted the parts during the breath, 1, 2, 3, 4. The right ventricular pressure volume loops just basically go to 0. There is nothing coming out of the right ventricle. But the left ventricle, the stroke volume is smaller, but it continues. And that's because of that reservoir you have in the pulmonary circuit, what I call pulmonary buffering, which allows for the 3 or 4 beats for the left ventricle to still be filled and things to continue. So we do have a fall in pressure, the typical reverse pulsus paradoxus. And the magnitude of this will depend upon the ventilatory rate, depends on the heart rate, depends on how much volume you have in the pulmonary circuit. It'll depend upon the left ventricle because that affects the volume you have in your left ventricle. So all those things will affect this pulse pressure variation that you see. Okay, what about when we change alveolar pressure or transpulmonary? So here is the pulmonary artery, here is the left heart, and again the pressure volume loops. So now you can see the right ventricle still keeps pumping, and of course it doesn't fail because it's a computer model, although I can put a limit on the pressure and make it crash. I can do that, but here it is just working away. And now the left-sided volumes are dramatically decreased because we have our obstruction distal to that pulmonary buffer, and you get very large pulse pressure swings. Now, I'm not showing it here, but one of the things I could play with in the model, I could actually volume resuscitate it. I just increase the total stress volume. And interestingly, if I resuscitate with volume or increase stress volume with pressure variations, as is well known in the literature, I can correct the pulse pressure variations by doing that. But when I do it, when this is the situation, it actually increases the swings because it actually increases the filling to the right heart, and they get even bigger rather than smaller. So it won't affect these. Now, an important difference is these tend to be timed with inspiration versus the ones with pleural pressure are timed on expiration. Now, just to finish off the last slide, it gives us a chance with the model. I can actually measure the volume in or estimate the volume in all the compartments. So under the baseline conditions, this is the volume in what I call the bathtub, or the systemic veins. This is the arterial, this is the pulmonary venous, and this is the pulmonary arterial. So with the application of pleural pressure, you'll see that the mean systemic filling pressure, or the volume in the systemic veins, slightly goes up. It's a big compartment. A little decrease in the artery, and the decrease in the pulmonary veins, which we know. That's the way we often use PEEP, is to decompress the lungs if somebody's in heart failure, and in the arterial. But when I change alveolar pressure, or transpulmonary pressure, I now shift volume from the periphery to the chest. And so now I have an increase in the pulmonary venous system, which is obviously not good if you have a leaky capillary problem. So creating a zone 2 condition actually will now begin to increase the volume of blood in the chest. And I think this is why there's been discrepancies in PEEP studies. Some studies have said that PEEP decreases lung water, and some say that it increases. I think it'll depend upon where you are. If you're creating zone 2, it'll increase. If you're just mainly the pleural pressure without zone 2, it'll decrease pulmonary venous pressures. And of course, these are amplified by changing cardiac function. So what I've done here is I just decreased left ventricular elastance, which is easy to do. It's the slope, the end systolic pressure volume slope of the ventricle. So I've just reduced it down to about 1/4. So just doing that, you have, with the same total volume, you have less in the periphery and more in the lung, because now the left heart is not handling it as well, but the right heart's working well, so it can pump it into that. So you shift volume from your periphery into your lung, which is, of course, what we call pulmonary edema. And then when you apply positive pressure, well, yes, you correct that, which we all know happens. But if you create zone 2 conditions, you just make it worse. So in conclusion, small rises in pleural pressure decrease venous return and cardiac output and intrathoracic volume. But increases in transpulmonary pressure have little effect on cardiac output until you create zone 2 conditions. And once you create zone 2 conditions, then you actually increase volume accumulation, and at least in those parts of the lung. And if you have it in all the lung, then you'll create it in all parts of the lung. And I think this is something we have to think about in our trials as we're looking at what we're doing with our PEEP. If we are creating these zone 2 conditions, we really are increasing the volume and potential injury to the lung. Thank you.
I apologize. I think we're running a little bit behind, so I'd like to invite people with questions to come up and ask Dr. Magder. Thanks, everyone, for attendance in this session. I thought that was fantastic physiology. I really enjoyed it.